light dimmer too?
Yes, I'll turn that for you.
Thanks.
I like this thing.
All right, guys. We can get started. I'm sorry I'm a couple minutes late here. So we're going to talk about cardiac phys and anatomy today, and I inherited this lecture from somebody last year, and so this is the first time I'm giving it, so bear with me. It might be a little rough. It's a lot of stuff to cover, and I had to pick and choose, I think, some of the more important parts about the phys and the anatomy. So I know you get that long, I don't know, you guys get that long list of all the topics that the ABA covers. It's a very long list, and surprisingly, when you actually go back and try and find old board questions related just directly to phys and anatomy, there are about zero. So I think a lot of this is primer for when you get your talk about cardiac anesthesia and CT anesthesia, because most of the questions you'll probably see on your written boards or oral boards are going to be kind of more related to that, but you need to have an understanding of the phys and anatomy to sort of get to that next level. All right. Okay, so we'll talk about the cardiac cycle. A lot of this should hopefully be some review. A lot of you did all this jazz in med school. A little bit about ventricular performance, a little bit about coronary anatomy and perfusion, some common cardiac reflexes that you might have questions about, some of the neurohumeral stimulation of the heart, and then my 2 slides on other important circulatory systems, which will mainly be 1 slide on the pulmonary system and 1 on renal circulation. It doesn't necessarily mean you shouldn't know, about other organ systems, but that's about all I could swallow in this lecture. Okay, so the cardiac cycle. First question, and I don't have that many, so I won't really go around the room, but in a normal person, percentage of cardiac output dependent on the atrial kick. I hear 25%. Anyone want to agree with that? You'll agree with that. Okay, all right. So yes, you are correct. The answer is 25%. All right, so cardiac cycle, you have both sort of the mechanical portion, which can be illustrated in pressure waves and pressure curves and all sorts of diagrams of pressure versus volume. And then you have the electrical sort of portion of it, which is your EKG. 2 main parts of the cardiac cycle, right? Systole, contraction, diastole, relaxation. You can, open up Miller, Barish, whatever textbook you want. There are about 25 different diagrams to diagram the cardiac cycle in all sorts of different ways based on, ventricular action, atrial action, your CVP, your art line, your EKG. And to go through all of it would be tedious and very boring. So, but we'll talk about sort of, the big overall picture of the cardiac cycle. It usually will start with, and remember it's a cycle, so you can pick anywhere on the wheel where you want to start it. But atrial contraction, which sort of lines up with your P wave on your EKG, right? And then you have this whole sort of isovolumetric contraction, which is typically the first part of ventricular systole. Ejection from your ventricles, it has an early part and a late part. And then you get relaxation of your ventricles, which is the first part of diastole, and that usually lines up with your T wave on your EKG. Passive LV filling, again, as the mitral valve and the tricuspid valves open. And then a period of what they call diastasis, which is still kind of slow fill, or still some passive filling that's occurring. It's not just a period of equalization, but you still get some filling. And then it starts all over again with your atrial contraction, valves close, ventricle squeezes, starts all over again. Make sense? Okay. Diastole is pretty much ventricular relaxation, and it has 4 big phases. You get the relaxation of your ventricle, the rapid LV filling again, the diastasis, which is sort of a slow but still filling of your ventricle going on, and then later atrial filling with left atrial contraction. And most of your LV filling, about 75%, is going to happen early on, and then your atrial kick is going to contribute about 25% at the end. And again, just a graph of the 4 main phases of diastole. Okay, so diastolic function has become really kind of popular, especially when you talk about congestive heart failure nowadays, and people probably over the past 10 years have figured out that diastole is a pretty important part of the cardiac cycle, and that congestive heart failure a lot of times is based on the ability or the inability of your ventricle to relax, more so than systole or ventricular contraction. So things that can affect your diastolic function. So your volume, the amount of blood that's going to fill, basically your compliance or the chamber stiffness of your ventricle, the recoil of the ventricle, which is how well kind of the myocytes can like contract and release, how well you can sort of get your contraction going. Catecholamines, so we'll talk briefly about sort of the neurohumoral stimulation of the heart. And then atrial function, because 25% of filling is going to occur with your atrial kick, and how well your atria contract is going to have a big impact on how your ventricles fill and contract. Dysfunction or diastolic dysfunction or systolic dysfunction of the heart usually is the reduced ability of heart to eject blood. So that's talking about your ejection fraction, which we'll talk about. Diastolic dysfunction, decreased ability of the heart to fill with blood. Okay, ventricular performance. Y'all remember, I mean, it's basic formula, but you can figure out a lot of stuff with cardiac output. Cardiac output, two main determinants, right? Stroke volume and heart rate. Your determinants, there are three main determinants of stroke volume plus a couple other more minor determinants. So preload, afterload, contractility. Any sort of dysfunction, such as wall motion abnormalities, you got a clot in one of your blood vessels, infarction, or valvular dysfunction can also affect your stroke volume. Heart rate is basically your intrinsic function mostly of your SA node. If your SA node isn't working, you don't get your atrial kick. And then just a reminder, your cardiac index is your cardiac output over your BSA, and normal is about 2.5 to 4, just as you see that a lot on echo reports and that sort of thing. Okay, so we'll talk about preload, afterload, contractility. Frank-Starling's curve, very important. There's usually a couple questions, and I just couldn't find any really good questions looking in the old ITE exams about Frank-Starling's law, and a lot of times they'll ask you, what can you put on the x-axis? And typically you're going to have left ventricular end diastolic volume versus stroke volume. So, as your end diastolic volume increases, your stroke volume should also increase, but you reach a peak in your curve where you're going to flatten out. You're not going to get any more bang from your buck. You're not going to have, and no more volume is going to impact your stroke volume, and eventually you're going to have so much volume that your ventricle is going to not be able to contract well. It's going to be overloaded. Your stroke volume is going to start to go downward. So really important curve. You can put left ventricular end diastolic pressure instead of volume. You can put certain like pulmonary artery pressures instead of volume. There's a lot of different x-axes you could label that. That is going to have the same relationship with stroke volume. Let's see. I think that's it about that. And then, depending on your dysfunction or what's going on with your patient's heart, your Frank-Starling curve may shift. A left shift in the curve is going to usually mean you have some sort of increased inotropy for whatever reason. And then right shift in your curve, decreased inotropy, shock, that sort of thing, adrenal depletion, A few other things about preload, other determinants of your ventricular filling, right? So we talked about, and some of these are sort of hammering home the same points over and over again. Your venous return, that's going to depend on how much volume you're going to get in your ventricle, your intrathoracic pressure, and we'll talk about Valsalva maneuvers as one of the sort of cardiac reflexes. Patient position, any sort of pericardial disease that's going to restrict your contractility of your heart. Heart rate, again, your atrial kick, important, and then diastolic dysfunction will also affect your preload. Okay, so afterload. So afterload is basically the systolic load on the ventricle after ventricular contraction has started. And a lot of afterload depends on your compliance of the first part of your aorta, right? Because it's going to be the pressure that the ventricle is ejecting against to get the blood past the aortic valve, then into systemic circulation. So, determinants of afterload, a lot of time wall tension, and we'll talk about Laplace's law, I think I have a slide about that. Your pressure in your left ventricle, the radius of your ventricle, more dilated means you're going to have more wall tension, going to be harder for it to eject. And then thickness of your left ventricle, global hypertrophy of your ventricle over time, will also impact your afterload. And then we talked about aortic compliance a little bit. Remember your SVR equation. I think there's usually maybe a question or two calculating SVR to know the components of that. Normal SVR, just to remind you, is usually 900. I think about 900 to 1600, 900 to 1500, whatever, depending on what you're reading. And then diagrams to just basically show you how afterload can change with, again, sort of a Frank Starling curve, your end diastolic volume versus your cardiac index, which is like your stroke volume if your heart rate is maintained. And then finally, contractility. So intrinsic ability of the heart to pump against, in the setting of normal preload and afterload. There's a lot of, like, if you read Barish and Miller, I was surprised about how much of the chapters are concentrated on talking about myocyte function and the different types of cardiac cells, and they get into a lot of sort of like the mechanical and sort of the actin myosin and all that jazz. And so I didn't really concentrate on any of that. You can certainly read it. I don't think in terms of exams that it would show up. You may have a question, but I don't think you'll have like an overabundance when you're talking about CV phys and anatomy. But a lot of it is based on your intracellular calcium for your contraction of your myocytes, just in case there's a code. You still carrying the code pager? So contractility can be changed by a lot of things. So your oxygen, blood oxygen concentration, acidosis will decrease contractility, depletion of catecholamines. So if you don't have norepi or epi, that's going to affect things. Loss of muscle mass. So if you have a big infarction and the myocytes die and can't contract. And then a lot of our anesthetics are going to depress contractility. A lot of our IV anesthetics definitely are volatile anesthetics. Certain antiarrhythmic drugs obviously can change your contractility as well. We're typically not giving those on a daily basis, though. Okay, so briefly about ejection fraction. So your normal volume and sort of just a normal 70 kilo male heart of end diastolic volume is about 120 mLs. The normal stroke volume is about 80 mLs. So your ejection fraction is 80 over 120, which means that's why usually we're looking for an EF of 55 or 60% or greater, right? Makes sense in terms of your just ratios. Another formula for EF is your end diastolic volume minus your systolic volume over your end diastolic volume. I think it's just easier to think of stroke volume over your end diastolic volume. Heart rate, primary determinant of myocardial oxygen consumption. So when we talked about the whole 6 parts of the cardiac cycle, every beat of your heart goes through all 6 parts of that cardiac cycle, right? So, and that all takes oxygen and ATP molecules and, I don't know, maybe photosynthesis or something like that. So the more frequent beats of your heart, the more oxygen that's consumed. So makes sense, right? Assessing how well your ventricle is performing. So, we talk about preload and afterload and contractility and all that jazz. But how can you actually assess how well your ventricle is contracting when you're in the operating room? And there's a lot of different ways you can do it. Textbooks will show you pressure volume curves, which are really hard to, generate clinically in a patient. You can do certain echo maneuvers. Please don't ask me too many questions about that. I don't do echo. That can be for next week. But you can certainly calculate your ejection fraction based on echo. And you can also, I think, do sort of this thing called DPDT, which is measure your LV pressure rise during contraction as well. And then you can measure diastolic dysfunction by certain maneuvers as well, which can also help you assess how well your ventricle is working. I just included this again. You'll see pressure volume curves in textbooks as well. You'll probably at some point maybe be asked to determine different valvular abnormalities or in different cardiac disease states will make these pressure volumes curves shift, wider, taller, that sort of thing. But it was too much to kind of get through this lecture. But just so a normal pressure volume curve, again, going through the whole cardiac cycle. Okay, briefly about coronary anatomy and perfusion. So heart's kind of interesting. It's the only organ that furnishes its own blood supply. It's kind of cool. Okay, so which of the following is a primary factor in regulating normal coronary blood flow? The primary factor. How many people say A? Okay, one for A. B. One for B. I'm just going down the line. C. 2 for C. Okay. D. 1, 2, 3, 4, 5. Okay, D. 5 for D. E. Nobody. Okay. So the answer is D, in fact. Oxygen consumption is the primary factor in regulating coronary blood flow. Okay, next question is, the primary determinants of myocardial oxygen consumption from most to least important are preload, greater than afterload, greater than heart rate. Anyone? Not really seen anybody. Okay, heart rate greater than preload, greater than afterload. Oh, maybe one. Okay. Afterload greater than preload, greater than heart rate? No. Heart rate greater than afterload, greater than preload? Oh, wow. Okay, well, I'll just stop there because that's the answer. That's right. So remember, we talked about heart rate being extremely important. And then, afterload, it sort of makes sense because, that's going to determine getting the blood from the ventricle into the aorta, and then that's how you're perfusing your heart, right? It's going to then distribute through your coronary vessels. Not that preload isn't important because that's sort of the volume of your blood that you're cycling through. All right. Let's get that. Okay. So you have, two main nodes that help conduct the electrical conduction system from your heart. You have the SA node, probably the most important, the AV node. Your right coronary artery is going to supply your SA node most often. It's about 60% of the time. Definitely going to supply your AV node. It goes through the bundle of His, which gets supply from the LAD and the PDA. And then I won't really mention your papillary muscles too much. Remember, when they talk about coronary dominance, if someone is right coronary dominant versus left coronary dominant, that's just talking about what the posterior descending artery supplies. And that sometimes can be a question, right? This one right here. So if your right RCA is going to supply your PDA, you're labeled right coronary dominant. And this is all determined mainly by cath, right? You have to actually shoot dye and actually see the circulation to figure this out. And then if your LAD is supplying your PDA mostly, then you're left coronary dominant. Distribution. So remember, your RCA is going to do most of your right ventricle. Your LAD is going to do most of your left ventricle, and your circ's going to hit a little bit of your left ventricle. And remember, the LAD will do a little bit of your right ventricular wall, too, as well. Your coronary veins, also important because it does drain blood back into the heart. Most of them are unnamed. You have the great cardiac vein, which I guess is probably the biggest vein. It does run sort of parallel with the LAD. You do have an anterior cardiac vein that pairs up with your RCA in the middle, which pairs up with your posterior descending. And 85% will mostly empty into the coronary sinus. So sorry, that's misspelled. In your right atrium. And then some will directly empty into your ventricle via the Thebesian veins. Coronary perfusion. So your coronary perfusion is based on, sort of like when you talk about cerebral perfusion a little bit, it's based on your diastolic pressure minus your left ventricular end diastolic pressure. And a lot of it is affected by, when you talk about, perfusion of your heart, supply versus demand, right? Especially in terms of oxygen consumption. So supplying your heart is going to be, your heart rate is going to help supply the blood. Oxygen content, coronary vessel diameter, right? If they're narrowed and all stenosed and all nasty, then you got problems. Demand of the heart are going to be basal oxygen requirements to keep the heart pumping. Again, the heart rate, your contractility and wall tension, which is also going to eat up oxygen. Okay, Pusasia, okay, something like that. I'm never very good at pronouncing it or spelling it for that matter. So coronary blood flow, and this really is flow through any sort of vessel, right? This is very useful when you're talking about catheter length, catheter diameter, when you're putting in peripheral IVs or arterial lines or central lines, any sort of tube where you're going to have flow through it. This physics law is very useful. And it's directly related to the pressure, the fourth power of the radius, and then over the length and viscosity, I do believe. And so remember, the longer the catheter, the more resistance there's going to be to flow. And then the bigger the diameter, less resistance, and that sort of thing. So resting coronary blood flow is about 250 mLs per minute. It takes about 5% of your coronary output when you think about everything else that the heart has to supply or your blood volume has to supply. That's a decent amount. And remember that the left ventricle, which is ejecting most of your blood into your systemic circulation, is perfused during diastole. And so that's why diastolic pressure is so important. I'm going the wrong way. So when we talk about coronary perfusion, remember your diastolic pressure is the first determinant of your coronary perfusion pressure. So if you have low diastolic pressure, you better have really, really low end diastolic pressure to get good coronary blood flow. And so that's why older folks, when they have really wide blood pressures, when their diastolic blood pressure is low, their mean arterial pressure may be okay because their systolic blood pressure is so high, but their diastolic blood pressure is really important too because their coronary perfusion is based on that pressure. So a pressure of 150 over 40, your map's not so bad, but you do worry about coronary perfusion. Make sense? Okay. All right. Oxygen delivery demand of the heart. So you do have you don't have a whole lot of reserve in terms of oxygen supply to your heart because really your coronary vessels are typically going to maximally extract oxygen at all times. So there's not a whole lot of buffer there if you have some sort of disease state or something like that. And your catecholamines, beta receptors, maybe nitric oxide can regulate a little bit vasodilation and autoregulation of your flow, but it's not really well known. And your myocytes will pretty much extract oxygen maximally at all times. So again, there's not like a good buffer system. Let's see. So if someone does have coronary artery disease and they're coming to the operating room, right, you got to want to keep your supply up and your demand low. Makes sense. So you want to maintain their oxygen saturation. You want to keep a perfusing rhythm, so usually a sinus rhythm. You want to maintain their cardiac output, kind of keep their stroke volume at normal, maintain their diastolic blood pressure so you get good coronary perfusion. Let's see. I think that's all I'll talk about on that side. Okay. Myocardial ischemia happens when O2 demand exceeds supply, right? Causes of ischemia in the heart. Acute thrombosis, probably the most common when you have a plaque and it ruptures and then you get an acute restriction of blood flow in your coronary vessels. You can have excessive metabolic demands, which sometimes we see in the operating room when patients are under a lot of stress with surgery. Could be also drug ingestions, amphetamines, cocaine, and then coronary artery vasospasm, which is also called Prince-Metters angina, where you get sort of this vasospasm of your arteries, and they kind of close down without necessarily an obstruction, mechanical obstruction like a plaque or a thrombosis. But you can still see ST changes and decreased coronary perfusion and signs of ischemia with that. Okay, questions about that? No? Okay, we'll talk about some of the neurohumoral mediators and then some of the common cardiac reflexes you'll read in textbooks. So, your innervation of your heart. Again, it's really your PNS and your SNS, right? Your PNS plays a pretty big role. It's mediated by the vagus, a little bit by the medulla. It does innervate resting pacemaker cells. So it will influence your heart rate and your conduction pathways. It doesn't really affect contractility too much. That's more your SNS. your innervations from your sympathetic nervous system mainly comes from C5 to T6, from the medulla through the spinal cord. Through that section of the spinal cord will innervate the heart. Remember, your acetylcholine is your pre- and postganglionic mediator for your PNS. Your norepi is your postganglionic for your SNS. And so the norepi will stimulate your beta receptors and as well as directly stimulate your myocardium. So you're going to have a big effect on chronotropy and inotropy. Okay, so hormonal influence on the heart. I'm not going to go too much into this either. You have a lot of different hormones that can influence your heart function. This, I think, came from Miller, Big Miller, and you can see like you have most of these will actually come from cardiac myocytes and be secreted from cardiac myocytes. So you have aldosterone, angiotensin, your natriuretic peptides, vasopressin, VIP. A lot of those will increase in secretion with congestive heart failure. And then you can see some do have an effect on inotropy, like angiotensin, vasopressin, VIP. Neuropeptide Y, I don't know too much about, but it has a negative inotropic effect on your heart. Okay, so remember your baroreceptors and your chemoreceptors of your heart. Cardiac baroreceptors. They help maintain blood pressure via negative feedback loop. So they're located in your carotid sinus and aortic arch. Get a rise in blood pressure, they stretch the receptors. You're going to have a resultant decrease in your heart rate and decrease in your SVR. And this receptor is inhibited by most of our anesthetics, so keep that in mind as well. Chemoreceptors. Does anyone remember what the chemoreceptor does or what it responds to? So oxygen tension, really, or your PaO2, located in your carotid body, not your carotid sinus, stimulated by change in pH and blood oxygen tension. And it really has to get pretty low. So your PaO2 usually has to get below 60. Most textbooks will say even below 50 to really get a response in that cycle. And so you're going to have an increase in respiratory drive, increase in respiratory rate, tidal volume, minute ventilation to try and improve your oxygen tension. The Biesel-Jarisch reflex, one you see every day. And this is basically saying that an increase in volume in your ventricle related to increase in preload or whatever, if you give someone like a lot of fluid or something like that, you're going to have a decrease in heart rate in MAP. And this is just a vagal response, really, is what it is. But they do give it a name. The Bainbridge reflex. So this mainly has to do with your right atrial stretch. So anything that stretches the right atrial wall, again, increase in volume or filling pressures results in an actual increase in heart rate. It will stimulate the SA node. The Valsalva maneuver. Now, that's something you kind of see every day. If a surgeon asks you to give a Valsalva, or if you for whatever reason you're giving someone a Valsalva maneuver through the endotracheal tube. So forced expiration against a closed glottis, right? You're going to increase your intrathoracic pressure, right? Lungs kind of are expanded, so your venous return to your heart, your preload is going to decrease. So you're going to have a concomitant rise in your heart rate, right? So decrease in cardiac output, usually blood pressure, concomitant rise in heart rate to try and get your cardiac output back normal, right? So if you all have done that, squeeze the bag, hold 20 centimeters of water pressure, typically you may see the heart rate go up, blood pressure go down once you release it. Okay, finally, other important circulatory systems, the pulmonary circulation. Important, but we're not going to get into too much detail about it. You have low pressure, high flow state. Remember, your right ventricle is very thin-walled, more compliant, not going to generate high pressures. And so the circulation through your lungs has to be lower pressure because your right ventricle is supplying your pulmonary circulation. And typically, your pulmonary resistance should be about 1/5 systemic. So even if your pulmonary, even if say your systolic blood pressure is 120, 1/5 of that should be about 20 or so, 20 or 30, and that should be your PA pressures, right? Or at least your systolic PA pressures. The 5 functions of your pulmonary circulation: you're transporting metabolic products, you're transporting blood to the lungs, you're serving as a reservoir for the left ventricle, transporting gas and fluid, and then a little bit of filtration system as well. And then final, renal circulation. Kidneys are important and very much auto-regulated, sort of like your cerebral perfusion. Not really going to talk about that too much. So your perfusion stays constant over a certain map, just like your brain perfusion. And renal blood flow is typically an excess to amount needed, so there is a buffer system there for your kidneys. Even if your cardiac output or your blood volume goes down, there's a little bit of a buffer system. Okay, that's it. Not my strong suit, but that covers coronary phys and anatomy, or CV phys and anatomy. Questions about that? Cardiac cycle, coronary anatomy. Yeah. There you're looking for, I'm sorry, did someone say something? They're usually actually looking for, a leak, and so sometimes they can see air bubbles if you're increasing pressure. If they have some sort of leak, they might sort of see a bulge in, like if you're doing spine surgery, sometimes they can see a bulge in the dura, or brain surgery. Sometimes when some of the surgeons do thyroid surgery, they're looking for any excess bleeding with increased pressure as well in the neck. When else do we do Valsalvas? When else has people been asked? Any other times? I can think of neck surgery. I can think of back surgery. Why they did it? Usually a lot of times they're looking for some sort of either increased pressure from bleeding, fluid leak, that's what I should say. Some sort of fluid leak, blood leak or whatever, yeah. Yeah. It's not, because it's forced expiration against a closed glottis, and we are sort of we are closing off the exhalation portion by generating pressure through the circuit. Does that make sense? Yeah.